Did we get everyone, Karina? Okay, perfect. Well, thank you all again for being here, both in person and online. Scott Houchin was nice enough to come in and join us in person, which we were just talking about how novel that seems to be seeing each other actually in anything except for over the computer. And so it's maybe means the beginning of a new era, and I'm looking forward to the opportunity to do more of that, because although it's great to see you all on the screen, it's even better to see you all in person. So thanks for coming in, Scott. This brings us to the next item on the agenda, which is an opportunity for public comment. Any member of the public may address the subcommittee for a period not to exceed 3 minutes on any issue not on the subcommittee's agenda, and the MAC will listen to all communications but may not take any action. So any public comment? Okay, hearing none, we'll move on to the next item on the agenda, which is approval of past MAC meeting minutes. There were minutes from the May 12 MAC meeting that you should have access to and hopefully have had an opportunity to review. Any comments on the minutes?
I'll motion to approve.
I second. Tina Nieto.
Okay, thank you. So we have a motion to approve and a second. And all those in favor of approving the May 12 MAC meeting minutes? We'll have to do roll call.
All right, I've got that. See, Dr. Klinsky made the motion. Dr. Hawthorne,
I approve.
Dr. Greenson, Dr. Greenson, you're muted if you're trying to speak.
Sorry there, having some tech problems.
No worries. Thank you. Christy Soboleski,
I approve.
Tiffany Wallace,
I approve.
Dave Craddock, Dave, you're muted if you're trying to speak.
I'm sorry. Aye.
Thank you. Scott,
Oh, aye.
Will Hillett,
Aye.
Jeff Horner,
Jeff Horner, aye.
and Chief Nieto seconded, so.
Aye.
Is that everyone?
Motion carried.
Okay, motion carries. Very good. Thank you all. The next item on the agenda is correspondence, and do not believe we have any specific correspondence, which brings us on to EMS agency updates under reports with Teresa Rios.
Thank you, Dr. Brewer. Good morning, committee members. Your agenda packets included a staff report highlighting some of our system accomplishments as well as projects that we have in progress. I don't want to go through the entire list, but I do want to highlight some of them. For example, our EMS annual report, we provided a presentation to the Board of Supervisors in May following the EMCC meeting. And our report received many compliments, both the presentation of the information and the amount of work that the EMS agency has accomplished. And by that, we really should say that the system has accomplished. The staff report mentions that we have filled positions in the EMCC committee. There were, some of them were vacant for a very long time, and then we are filling the positions with an eye toward diversity. The same can be said for the MAC committee, and we need to highlight that. We are very happy to have representation from South County, and that at this time, we only have one member position vacant in the MAC committee, which is a paramedic position, and we're going to be recruiting for that in an alternate. So we hope to have that filled by September. We're also going to be working on the alternates. We have done a really good job, and thank you, committee members, those of you who have already helped us to identify somebody who can be your alternate. It is very helpful when you point us in the right direction, and then we can do the rest. So we'll be reaching out to some of you who do not have an alternate at this time, so that we can fill those positions as well. In terms of activities, I want to highlight the fact that we are working with our mobile app developer to expand the use of our EMS mobile app to provide real-time push notifications to the users. And it's also right now part of the way that it's set up is that we're having to update the mobile app and the website at the same time. So we're trying to mainstream that in, work with the developers so that we can do only one update, minimize the chances for error. And we update on the website, and it updates the mobile app automatically. So we're trying to make sure that we get that done this year. We have a team of individuals who are true experts in their field with many years of experience, but it doesn't mean that we cannot continue to learn. So one of our goals that we have is to continue to expand our capabilities in identifying training that would be beneficial, not just to the team, but also that we can bring to our stakeholders. And is another area that we're focusing on this year. And another project for us is strategic planning. The EMS agency engaged in some strategic planning back in 2017. We presented a strategic plan that we had for the agency back then. And we really haven't done that work. We did a strategic planning when we were running the RFP just to do a system assessment, but with that in mind, that we wanted a plan that would inform the RFP. At this point, I think we want to focus on doing an internal strategic plan, and the goal is to eventually engage the stakeholders in system-wide strategic plan. For the rest of the items, I don't want to go into those. Staff will provide the committee with more detailed updates regarding the accomplishments and some of the activities that we have in progress. And I'll be happy to answer any questions.
Thank you, Teresa. Any questions regarding the EMS agency updates?
Dave Pratt raises his hand.
Dave, did you have a comment?
Yeah, just mostly a question as far as I know that there are technical challenges with getting the updates out, but some of the feedback that I've gotten from our field personnel is if we have updates that become effective, that they can be available on the app and on the website, and that people don't have to refer to their emails. And I know it's something you guys are working on, but I just wanted to share that that's been a continuing source of feedback from our personnel, as if I could bring that to the request of the committee so that when we have future updates, our people are able to go to their references on the web and on the app and actually find those. Thank you.
Absolutely. Thank you, Dave. And I agree. And we're actively working on modifying both of those routes of communication so that we can have more real-time updates available and references available online and through the app. So it's a work in progress, but it's definitely on our radar. So thank you for that. Any other comments? Okay, thank you, Teresa. That'll move us on to old business. And the first item under old business is EMS agency response to COVID. Jeff has a report for us.
I'm pleased to see one of my old partners here. All right, that's quite a surprise. The EMS agency has, I wrote something that will be in your agenda packets, my report, but I'm going to just mention something at the bottom, which is that our small team has done a lot of work I'm impressed myself with the whole team and the amount that actually has happened in the past year for just a handful of people here. We're always the last to leave the building, let me put it that way. So the COVID-19 public health emergency is not over. We're optimistic. Things look great, of course, in general. We'll talk about the slight uptick in a moment of cases. But I do think we've certainly made it through the worst. And even if we get another mini surge of some kind, I think, I can't imagine anything getting worse than December as far as just numbers and sheer impact. Despite the challenges along the way, the local healthcare community has been generally successful in the response to the pandemic. Everybody out there, countless agencies and organizations, public, private, everybody's pulled together. I've been a part of it. We've all been a part of a lot of collaboration, and it's something that we're very proud of. The agency, certainly proud of what we've done and taken initiative on our own achievements, and we are confident we made a difference. Early in the pandemic, the EMS agency responded swiftly by staying informed, first and foremost, even at the very end of 2019, through the CDC, the CDPH, and the EMS Authority. The agency first took some real action with emergency medical dispatchers, adding screening questions, creating some new protocols and policies to protect first responders in the field from possible infections and exposure. Those policies have been reviewed throughout the past year as well. Through the agency's MOAC function, as you all know, we've procured tremendous volumes of PPE, millions of individual pieces of this and that, from gloves to gowns and everything, ventilators, oxygen concentrators. We've brought in, the MOAC function of the agency has brought in much of the testing and vaccination supplies that the county has used, and a range of other products. We arranged for some staffing at a time when there were some real crises in that realm. We've worked with the EMS Authority and local service providers and the chiefs and everybody, thank you, to expand the scope of practice of EMTs and paramedics to be trained first to administer COVID tests and then to administer vaccines. And I should throw in something that I haven't written here, which is that we're going to be looking at the end of those LOSOPs in the weeks to come. That announcement is on the horizon, excuse me. We've done many little things that don't even go noticed by the beneficiaries of these policies and enactments. And again, I'm just very proud of my involvement with this team in the past year. And I think we've really played a role. Things are not over, as some of you, most of you, I'm sure know. We've seen a slight uptick in cases. The Delta variant is definitely in the state and on the scene. We have more than half, I think 50 some odd, somewhere 55% are floating in there of new COVID cases of the state are the Delta variant. Right now we have 7 hospitalizations in Monterey County and 2 in the ICU. This is yesterday's data from our hospital preparedness program. So we were floating at 2 to 3 people hospitalized for several weeks, just a few, and 7 is still a very, it's a nice number. It seems very manageable, but things have not been flat as they had been for the past couple of months. We are seeing a little bit of an increase. So just not to bum out my little speech here, but we need to stay vigilant and not let our guards down. The EMS agency is definitely vigilant. We're still monitoring reports and data every single day. And we got our finger on the pulse, and we have a year's worth of practice and exercise now at making things happen. So thank you for all your cooperation, and thank you for the team.
Thank you, Jeff.
Any questions?
I got a comment.
Yes, sir.
I want to thank you for all your help securing PPEs. I think we were in a very tough situation, and with your assistance in the county, we were able to safely protect our personnel in the field. Can't show appreciation enough for that.
yeah, everybody was in a tough spot and
You know, when your vendors
Yeah.
are telling you, even at triple the price, I can't get it for you.
yeah. Right. Yeah, unprecedented use
Great work.
and demand.
Well done.
Thanks. Yeah. All right, any other questions?
Yeah, I would just reiterate what Scott had mentioned, and Jeff, we really appreciate all of your hard work on MOAC and PPE availability and managing resources and other supplies needed during the course of the pandemic. So I know we've said it before, but again,
Yeah,
thank you for excellent job in that process and for really, it's one of those things that kind of makes or breaks the response, right? And so if you can't get supplies to the boots on the ground, then you know it becomes an unmanageable pandemic, and so that it makes a huge difference. And so thank you for your efforts there.
I appreciate the acknowledgement, and I always say this to everybody too. You know, this has been not just our team with the EMS agency, but with members of the MHCCs, the Medical Health Coordination Center, of the CDPH, all the various agencies, you know, you and your peers. Yeah, I think throughout all of this, if we've learned anything, it's like that cooperation and collaboration can get a lot done. So keep at it. All right, thanks.
Thank you.
Okay, so that brings us on to the next item on the agenda under old business, which is item B, policy and protocol development cycle, July 1st, 2021 effective date. And Steve Brooks has a report for us.
Well, good morning, and thank you, Dave, for your comments. Hopefully we've addressed them. We've got the policies and protocols update onto the website. We are in the process of reviewing it, and it should be all squared away by tomorrow morning at the latest. So if you're interested in what you asked for, which is a single place repository and resource, it's the policies and protocols are on our website, and we are actively working with the app developer to get them on the app and get everything straightened there with the most current policies and protocols. It's been a process, and doing it in the middle of at the tail end of, if you will, a pandemic is always challenging because you're always pulled various ways, but it's there and they're in effect. And we've included the training documents that we send out with the policy and protocol process. Those are also on the website, including the most recent one, which was sent out, which was a small, mostly administrative changes that we found as we were getting all this posted and prepped for posting, and a few comments from field personnel who had eyes on the policies and said, hey, what about this? So we've created those administrative updates, and the guidance is on the website, and we've distributed to all the fire chiefs, training officers, people at AMR, hospitals. Everybody is, all the organizations have received them and should be filtering those down to the people who actually use them. At this point, are there any questions about the process? Thank you very much.
Okay, thank you, Steve. I know that I'm aware intimately of the amount of work that went into these policy revisions, and just again want to recognize the efforts that you put into this. For every hour that you and I spend talking, there's probably 30 hours of work that you're doing, on the back end. So thank you again for your work there. That brings us to the next item under old business, which is item C, which is addition of ketamine for pain management. And Steve, you have a brief report for that as well?
Very brief. We've taken the request for local optional scope of practice use of ketamine to the state, and Dr. Burley presented that there, and we've received approval to bring ketamine to the fine folks of Monterey County. So what we'll be doing is developing a public comment process, 21 days of public comment. It'll be starting, I believe, this week. As soon as we can get that out for comment, we'll distribute widely. 21 days, we'll review the responses, bring those back to this group, and have hopefully have endorsement to begin use of ketamine in Monterey County.
Thank you, Steve. Any comments on that item? Okay, it brings us on to the next item under old business, which is law enforcement requests related to blood glucose, jail, and medical checks. And Deborah has a report for us regarding that.
I'm going to take D along with item E as well, the disposition of intoxicated persons, because they're fairly related together. You have an updated draft of the intoxicated person clearance form attached to your agenda packet. We did make some changes based on feedback we received from EMS providers and EMS agents, or EMS leadership as well, from the various agencies. Our next step is that we are working to arrange meetings with law enforcement representatives to make sure that our policies and proposed drafts are in line with their practices and policies. Chief Nieto, if it's okay with you, I may be reaching out to you for some help with contact information for who to reach out to at the various jails. So, and you're muted, I think.
Tina, you're muted.
No, she's not.
I think.
I'm sorry. Yeah, he's got 2 mute buttons. Actually, I'm the president now of the Chiefs Association with the Dell moving on. So yeah, reach out to me because I'm the contact now.
Okay, perfect. I'll be doing that shortly then. Thank you.
I'm sorry, what? I can't hear you.
Michelle Kalinsky.
Michelle, comment?
Oh. Yeah, just a question because we frequently get these bounced back. Are they willing to take a systolic pressure of 200?
You mean from jail or?
Correct.
That's the next phase of our discussion. So we're going to be getting together, hopefully with the law enforcement representatives, and making sure what we have outlined there will be in line with what they're willing to accept. So we need to.
Perfect. Okay,
bring
because
those together.
they've bounced those out back for treatment occasionally. So just double check those numbers.
Yep, absolutely.
Okay, thank you, Deborah. Appreciate that. Which brings us to the next item under old business, which is interfacility transport using hospital RNs on the ambulance instead of the critical care transport team. And Steve, you have a report on that?
Very, very brief. As you can tell, there's lots of things I've been working on. This is one of them. And the point that I've been working on is the reporting form for the interfacility transports. And we're trying to gather some data to see what it is going on related to critical care transport. So the reporting form will have, as you can see in your packet, will have information beyond just the use of a hospital RN for the transport. We want to know if the medications or other treatments are discontinued and an ALS ambulance was used. We'd like to know if CCT was used and if the patient was defaulted to go by air. So we ask those things, the timing, so we can see the progress, help with as we try to understand the decision process for each of the patients, so we can ensure that the patients are moved in between facilities when they need a higher level of care at an alternate facility. So we'll be distributing this actual form, not just within your packet this afternoon. And please use it. We'll evaluate in 6 months, see where we're at. Any questions? Thank you.
Steve, this is Jeff Horner. Can you hear me?
Yes, Jeff.
Yeah, I'm sorry. I lost the signal, so I missed the very beginning of your report. I'm just curious, have all the hospitals in the county been engaged, and how receptive are they to the idea of sending nurses on the IFTs? Because having worked for a number of hospitals in the county, I know that in the past there's been significant concerns from risk management and mitigation, and also staffing implications.
Speaking generally, and if any of the hospitals want to speak specifically to their facility, a few of the hospitals are, they'd rather not, but they will send an RN from their facility when it's necessary and it's time critical. Of course, we do have hospitals that just don't have the staffing to send anybody out of their ER. And so it becomes problematic, and we would expect them not to do that under this option. And we'll continue to use helicopter, CCT, or just ALS transport. But in general, the concept has been well received by the hospitals, and we'll see how it works.
Can I be clear? I mean, so the workaround with using nurses from at least Salinas Valley Memorial is tenuous. There are union problems, there are safety concerns. It's completely a workaround until we can get the critical care transport issue solved. I mean, it's not an ideal solution, obviously.
And I'll to comment on that. Yes, it's maybe not ideal because it does take a nurse out of the ED, but it's one option among many, because we do have air transport, we have CCT, we have ALS. When the scope of need of the patient meets the scope of practice for the paramedic. So there are alternatives. This is just another bullet in the gun, if you will, that we can maybe use when necessary.
Right, but the main problem with this is we're not getting ground CCT in a timely manner, at least at my facility, in any type of routine manner. So that's why this workaround's been developed, but we would like not to be doing that in the future.
Michelle, you have a comment?
Oh, I just want to echo what Nick is saying. I mean, while we did put this in to try to get us out of really, really serious problems, obviously pulling a nurse out of the ED for a few hours is really suboptimal. So my last critical care transport was a new onset DKA, and I was given an ETA 8 hours later. By the time I would have gotten that ETA, I would have had that child fully treated. But you got to understand that then that's our nurse taking a one-on-one critical case for 8+ hours. So I think we do need to strive for better system management with the ability of a CCT to be available in a more timely fashion. And what happened in that case is actually it was less time for me to wait an hour and a half for Stanford's crew to come back from their transport, then drive all the way to Monterey County and pick up this kid. And we still beat our CCT time by 2.5 hours.
Can you provide specifics on that offline, so we can look into that? That seems a little excessive and not as our contract is intended.
Yeah, I can try to pull that information for you.
Yeah,
Dr. Hoffman, I'll say I've had several experiences at Me Memorial. Best case scenario is typically 4 hours, frequently 6 to 8 hours. And so we're typically getting Stanford CCT or a helicopter, and have kind of given up on the traditional ALS CCT combo over the last 6 months.
And that's again why the report form will be useful. We're trying to look at what's going on for these transports. So thanks. Any specifics that you can provide again offline would be helpful.
Can someone, it's 40, what's the contract state? 45 minutes for CCT is the contractual AMR agreement?
Depends on the hospital and where Salinas and Chomp are 45, and I believe it's an hour currently for Me Memorial.
Okay, right. So I mean, clearly that's not happening on a routine basis. So I'm glad we're going to start tracking it.
Right, and again, I really appreciate all of the information here. It's much more helpful to get real-time UOs and reports so that we can take that information back to the provider and work on solutions. As much as anecdotal accounts provide a sort of a snapshot of what may be going on. It's the data that really helps to drive negotiations and change. And so even though it may seem like, well, why are we, if we all kind of know what's going on, why are we turning in data and nothing's happening? It's that data that helps to drive change. So again, please submit reports when there's an excessive response time for CCT. Okay, well, thank you, Steve. Appreciate your work on that. And that brings us on to local optional scope of practice under unified scope. Do you have a report on that?
Also, much like ketamine, we took a local optional scope of practice for unified scope of practice for EMS providers, paramedic providers working on helicopters, EMS aircraft. The background on the issue is that our EMS aircraft providers have staff that work a variety of counties, a variety of bases, and because of the variety of counties and local EMS agencies under which they work, there are variances in the policies and protocols they work under. And it's problematic to have I'll use the example, a flight paramedic working in, say, Santa Clara County one day, a couple days later, they're now at a base in Monterey County, and they go out to a patient and they have to remember specific Monterey County policies and protocols because that's the county they're working in, even though their mind, the previous shift was on Santa Clara policies and protocols. And of course, this is just ripe for disaster. Probably not bad patient care, but administratively, it puts the paramedic at risk for violating the policies and procedures within the county that they're working. So in conjunction with our EMS aircraft providers, other EMS agencies, we have created a policy to allow flight paramedics to have basically a unified scope of practice underneath their medical director that is essentially common among all the local LEMSA areas. And we're joining this so that we can help make sure we've got good patient care and also keep our flight paramedics out of what I would call administrative risk of doing something that's approved in one area, but maybe not in Monterey County. So this has been approved by the state, and so we will also be bringing this along with the ketamine to the public comment process, and then back to this committee for endorsement.
Thank you, Steve. Any comments on unified scope?
It's Jeff Horner with CalSTAR again. I just want to take a moment and acknowledge your efforts, Steve, and the efforts and my appreciation for the agency's timely response to this. It is much appreciated, and it will help to streamline the unified scope and of practice for the flight paramedics working within the Central Coast and South Bay region across county lines. We're continuing to work with the other surrounding counties, Santa Clara, Santa Cruz, San Benito, and we'll be happy to continue to work with Monterey County for on any policy revisions needed and any indications for changes in system use. So again, my thanks to the agency.
Thank you, Jeff. Okay, that brings us to the next item on the agenda, which is local optional scope of practice for blood and blood product transfusion monitoring. And Deborah has a report for us.
And this is another item that we are hoping will help with addressing some of the challenges around at least a subset of patients who are requiring CCT transport. There's an updated draft of the policy and algorithm attached to your agenda packet. The modifications that we've made so far are based on feedback that came from the various QI committee meetings. I've also recently reached out to the base hospital or receiving hospital coordinators at the 4 hospitals, forwarded this policy along to them and asked that they send that along to their blood bank director. I think everybody has done that at this point. So we've been getting feedback and have received some from CHOMP and Salinas Valley, which we really appreciate. I'll be reaching out again to me and Natividad to see if there's feedback from those agencies as well. Our next steps are to work on incorporating those suggestions into the drafts and the algorithms, and then putting together some training materials and submitting the application to the state.
Great, thank you, Deborah. Any comments on that policy? Christy, I'm not sure if you're trying to make a comment. I think you're maybe muted if you're. We'll go on to new business, which the item here is helicopter transport out of county of patients 15 years of age or older. And this was a suggestion that was brought up at the last MAC meeting to put on the agenda for discussion. Dr. Kalinsky had made a recommendation that we consider notification of base hospital within Monterey County for any patient 15 years or older who was going to be flown out of the county to a facility outside of Monterey County. Michelle, did you have any, did I get that right? And would you like to make any other comments on that?
I think that this was in response to the trauma case that was taken out of county without base contact with Natividad, if I recall, that they had felt that maybe they could have optimally stabilized or so, if I recall.
Right.
I'm trying to pin this down. Can you refresh me on the case a little bit?
Right. So the case I think you're referring to pertained to a patient who was struck by a train and had 3 appendages traumatically amputated.
The reimplantation issue. So this is not, I don't know that I'm looking at this for anything, but I think for adult trauma, if you're bypassing the level 2, let's ask them if they have the capacity to treat this or if they want to evaluate this, because if I recall, this patient was not a reimplant candidate and took quite a while longer to get to a trauma center in the Bay Area and was able to be managed locally. So I just think it's worthwhile to make base with trauma center if you have a patient that meets major trauma criteria and you've got a level 2 trauma center sitting in your county. Let's get their advice on destination is my thought, rather than fly immediately. I don't know.
Right.
So
yeah,
this wasn't universal. This was meant for, I mean, I'm not sure we really fly much outside of that for adults, but this was meant solely for trauma evaluation to discuss it with the trauma center.
Mm-hmm. Yeah, and I kind of assume that was sort of the gist of the recommendation. And we actually do have that already in the policy under policy 4040, or can we pull that up?
All step 1, 2, and 3.
Yeah, so essentially,
Should make base.
and we'll see if we can get this on the board here. Policy 4040. All step 1, 2, and 3 trauma patients, the policy designates that base hospital contact will be made for all of those patients. And so that should satisfy, I think, the crux of your request there. We did notice on other policies, there's a patient destination policy that doesn't reflect that. And I think we could probably clean that language up in that policy just to kind of get the two in tandem. But if you could go down on this, keep going. Okay, go back up. Okay, stop. So under E here, base hospital contact with Natividad shall be made for all adult and pediatric trauma patients meeting step 1, 2, or 3 field trauma triage criteria. Base hospital contact may be made with Natividad for any questions for adult and pediatric patients meeting step 4 trauma triage criteria, or for any patients who do not meet trauma triage criteria, but whom the paramedic feels may benefit from a trauma center. Is this?
So this is a training issue, it sounds like.
Yeah, I think this is more just to remind paramedics that this is within the policy, and this should be being done on any patient that there's consideration for flying out. As I said, there are other policies. There's a patient destination policy that we also looked at, which didn't have this language in it, and so I think just for consistency, we should go in and make it make this addition to that as well, so that both policies reflect the same thing. But this is within our trauma policy already.
I think there's some inconsistencies as I pull up the policy on the website. It has the word may in bold print on there, and it doesn't appear here. So I don't know if there's a,
Okay, under E,
under E,
Okay.
yeah, it says you may make base contact.
we can look into that.
And I do seem to recall that being an issue, is that it wasn't mandatory that they could transport without, base contact and just call in the call. And I think my point is solely that if you've got an adult trauma center expertise sitting within your county, call them before you fly someone out of county. That's my only point.
Right, and we're in agreement with that as well. You want to see if it's, number one, if it's appropriate, number two, if the patient's clinically stable, or if the patient should be treated and stabilized at the trauma facility within county prior to being flown out for special needs. So we're in agreement, and we'll work on cleaning up the language on the website if there's an inconsistency there.
Thank you.
Any other comments or thoughts on that? What's that?
Can I stop sharing?
Nope.
Can I stop sharing?
Yes, thank you. Okay, great. Let's moves us on to the next item on the agenda, which is EMS System Quality Improvement Program and Continuous Quality Improvement Technical Advisory Group. Deborah has a report for us.
Yes, just going to hit several projects that we've been working on since the last meeting. We're moving forward with the standardization process for trauma patient PCRs. We have our first meeting for that group scheduled on Monday, July 19th from 1 to 3. I think I've heard from the majority of the agencies on this call. If you know someone else who may want to be represented on that, please reach out. The project between ESO and SVMH for integration of PCRs into the SVMH system and outcome feedback into the ESO system is continuing to move forward. It sounds like they've done some testing in the facility, and that's going well, and they may be establishing a go-live date for that soon. The trauma center designation agreement with Natividad was approved by the Board of Supervisors yesterday, and that will put that agreement into place until 2026. We're still working on Trauma One and getting the uploads to go smoothly between Natividad and our system, so that's still in progress. And that'll be for outcome information on trauma patients in particular. Get with the guidelines, outcome information and data for STEMI and stroke are moving forward as well. Those contracts are expected to be presented at the September Board of Supervisors meeting for their approval. We've also been working on a contract with CARES, the Cardiac Arrest Registry, for some cardiac arrest patient outcome information. The good news is with that is that the vast majority of our provider agencies and hospitals are already participating in the system. So that data is all there. This will just give us access to it. And that's again expected to be presented at the September Board of Supervisors meeting, along with the Get with the Guidelines. We're going to be starting to work on core measures soon. Those are due to the state on September 10th. And we should see that data at CQI tag as well once those are completed. Dr. Burley is working on revising some training for new base hospital physicians. That's just follow up on a topic from our previous meeting. And then we've moved forward with putting together a working group focused on air ambulance service, HEM stuff. We had our first meeting. We included stakeholders from the EMS agency, Mercy Air and CalSTAR in that meeting. We discussed a variety of topics, including incorporating their PCRs into ESO, some data sources and what information is available there. So that process is moving forward. We were planning on talking at Ops today on some particular data points that might be of interest to monitor, but that meeting was canceled. So we do have a follow-up meeting scheduled for this Friday, the 16th. So we'll bring up that topic there. And my goal is to come up with a list of data points to move forward with monitoring and bring that back to the group. The final item I have is that I think, as Teresa mentioned earlier, we're working on continuing to grow our education offerings directly from the EMS agency. And we'll be working on scheduling some classes presented by Dr. Burley on a regular basis. The feedback on the last one was very positive. So we're planning for a next class in October, some more information to come on that. We would love some input on particular topics that the agencies or field providers are interested in seeing presented. So feel free to send that to me in the meantime until I can get a survey out asking for that input directly. And that's all I have.
Thank you, Deborah. Any comments or questions? Okay, great. So that brings us on to the next item, which is future agenda items. Any specific items for future agenda items? Hearing none, we'll go on to the next item on the agenda, which is announcements for the good of the order. I understand Dave Craddock has been recognized and promoted to chief, and so wanted to congratulate Dave and do that publicly here. Congratulations, Dave, on all of your efforts and on your promotion.
Thanks very much.
Any other items for good of the order or announcements?
I have one, Dr. Burley. It is sad news. Jeff Deandra will be leaving the EMS agency this Friday, July 16. Deborah Hapgood, our EMS analyst, will be taking over the MOAC program. And our plan is to recruit for the position as soon as possible so that we can minimize the amount of time that that position remains vacant. And thank you, Jeff, for all the work that you've done. You have done a lot. Everybody has recognized everything that you've done when it comes to the MOAC program and all of your contributions to the EMS agency and the system as a whole.
Thank you. Been one of the most interesting years of my life. All my lives.
You didn't know what you were getting into, Jeff, when you started.
Oh, thrown into the fire for sure.
Okay. Any other items for announcements or good of the order? Okay, hearing none. Our next meeting date is scheduled for MAC is scheduled for Wednesday, September 8th at 8:30 a.m. Location and Zoom information to follow. Most likely it'll be very similar to what we have here, hybrid meeting. And that brings us to adjournment. So unless there are any other comments, we'll go ahead and adjourn the meeting. And thank you all again for being here. Always a pleasure to see you and work with you. And we'll see you next time at MAC. And for those that are staying on for EMCC, we'll see you shortly for EMCC.
Great. Thank you very much.
Thank you.